Namaste. This is week number 8 and lecture number 5. Today we are going to discuss some emergency situations in palliative care and which may threaten life of the patient. So, palliative care emergencies are basically 4 to 5 situations. First is spinal cord compression, another is superior vena cava compression, massive hemorrhage, seizures or hypercalcemia. So, these are all those situations which threatens the life or if left untreated result in poor quality of life. So, aim is to recognize the situation and manage it as far as possible. First of all, whenever you are handling an emergency situation, you have to keep few factors in mind. Firstly, try to identify the emergency, correct the correctable, general condition of the patient is evaluated and trajectory of illness, what is the status of the disease or stage of the disease should be evaluated. Communication with the carers is very important in emergency situation as well, and benefit versus risk involved should be judged. So, whatever intervention you plan to take up, you have to weigh the benefits against risk, and patient's autonomy and family involvement in decision making is important. So, it works on the EMA principle. EMA means evaluation, explanation, management, monitoring and attention to detail. As we said earlier, the few of the emergencies in palliative care palliative care patients are superior vena cava compression, spinal cord compression, hemorrhage, seizures, hyperkalemia, stridor and choking, very common in head and neck cancer patients, increased intracranial tension, acute breathlessness and delirium. Coming to first emergency, spinal cord compression, it occurs in advanced stage of malignancy, particularly patients who are having metastasis in the spine, vertebral column or a tumor pressing in the spinal canal, pressing on the nerve root or on the compression of the vertebra. Usual sites are thoracic, second on the list is lumbosacral and cervical. Vertebral metastasis is the main reason of the spinal cord compression and it accounts for 85% of spinal cord compression cases. Extravertebral tumor, intramedullary tumors are another reason, and intradural tumors from meninges arising from the meninges also can cause spinal cord compression and epidural metastasis. So, common malignancies which comes with this type of emergency are prostate, breast, lung, myeloma and kidney. So, whenever a patient of prostate, breast, lung, myeloma and kidney comes to you, you must keep in mind about the various metastases they might be having in vertebral column and which can give rise the situation of spinal cord compression. Coming to signs and symptoms of spinal cord compression, it depends on which area is affected. So, it can be a just starting point or it may be a very worsened situation where you cannot help the patient. Particularly patient will complain of pain at the site of compression, severe pain, then weakness in the lower limbs, and there will be sensory changes in the lower limbs like tingling, numbness, and sometimes even bladder bowel dysfunction is present, and there will be altered tendon reflexes. Pain is the predominant sign of spinal cord compression. It is about in 96% of the patient, and it might have started few months ago, and if it is neglected, patient will come only with the pain and spinal cord compression. So, the pain can be localized, referred or radicular. Localized constant pain increases when patient is lying down and may cause the patient to awaken at night, and pain exaggerated by recumbency and improved by upright position. Referred pain, it is seen in lumbar epidural spinal cord compression with L1 vertebra, and it is referred to the sacroiliac joint on the same side. And radicular pain, it is usually because of the nerve root compression from the vertebra from where it is arising, and it is referred to the lower limb. There is along with pain, you will find there is a signs of motor weakness. So, weakness in both the lower limbs, more proximally, then slowly it goes towards a distal part of the lower limb, and patient will describe that there is a heaviness in the muscles of lower limb. So, and there will be increasing in difficulty in walking, climbing or getting up from the chair and bed. Along with this, there will be usually sensory deficit which you have to evaluate, elicit in both the lower limbs, which can be paresthesia, numbness or loss of sensation, and it begins in the toes and ascends in stocking like fashion and eventually reaches the level at which the spinal cord compression has occurred. Autonomic nerve compression is very rare, and generally it comes very late in the phase of compression, and the sole presenting symptom of epidural spinal cord in epidural spinal cord compression, this is predominantly seen, and this because of this autonomic nerve distribution and its compression, there is a bladder bowel dysfunction. So, there will be constipation and urinary retention. Few patient has incontinence of the bladder bowel, and this leads to a very poor prognosis of the patient. It is a good one of the good prognostic indicator also. One who can walk before treatment has got good prognosis. So, but if it already starts with the paraplegia or loss of sphincter function and rapidly deterioration, then the prognosis is not very good and patient is less likely to recover from this complication of spinal cord compression. First and foremost investigation is MRI. It is a best diagnostic method, it is non-invasive. Plain X-ray not sensitive enough to show early metastasis in metastatic spinal cord compression, but sometimes it may be considered when because of the unavailability of resources. Goals of treatment is to first of all pain relief, minimize the complications of paresthesia or paraplegia, and stabilize the spinal column. Start with steroid therapy. This is the first and foremost, it is always at hand and you can do it immediately. Give pain relief measure and then consider for radiotherapy to the affected spine. Surgical resection and decompression may be a method of choice in a very fit patient or who has only few levels of compression or few vertebrae are involved, and adjuvant chemotherapy or hormonal therapy can be considered when the tumor is chemosensitive. Steroids are used as an effective adjuvant to the radiotherapy also and to the chemotherapy also, and this will help in reducing the edema around the spinal cord and inflammation. It will reduce the neurological deficit and pain control, and we can consider even very high dose like 16 to 32 milligram of dexamethasone given intravenously immediately. First and foremost, immobilize the patient, do not allow him to walk. Then anti-embolic stockings and prophylactic anticoagulant therapy may be considered if you are thinking about DVT. Moving and handling should be managed with the assistant. Skin assessment, bladder care, bowel care if patient is already bladder bowel involvement with constipation or urinary retention. And so, multi-professional team is involved in management of spinal cord compression, which can be a radiation oncologist, a surgical team or ortho-oncologist or neuro-oncologist are involved. As said earlier, the prognosis on functional augment pre-treatment depends on how the patient was before the treatment, whether he was ambulatory or not, and whether it is rapid development. If it is a motor deficit, the prognosis is poor, and visceral metastasis, again the prognosis is very poor. So, spinal cord compression, take home message: make the patient immobile, give him pain relief, give the large dose of steroid, then consider for MRI. After the results of MRI, one can consider 3 types of treatment: whether to go for surgery for fixation of the spine, whether to go for radiation to the vertebral column which is involved, or to go for chemotherapy. Of course, reassurance, bladder bowel care, skin care and support to the patient and family is very important. Coming to second emergency, it is superior vena cava compression. Superior vena cava compression syndrome is in this you will find number of symptoms present, and this happens because of the impaired blood flow through the superior vena cava to the right atrium. Here is the biggest vein, superior vena cava, which drains blood from the upper limb and from the brain, and the blood, desaturated blood enters into heart. If this vein is compressed by a tumor, here is the tumor, it will obstruct the blood flow from the head, neck and upper arm, and this will give lots of signs and symptoms, and because of the plethora of signs and symptoms, it is called syndrome. So, that is why it is called superior vena cava syndrome. This was first described by William Hunter in 1757. Usually tuberculosis and syphilitic aneurysm used to be the cause of superior vena cava syndrome in those days, but now malignancy is the first cause of superior vena cava syndrome. So, any tumor or node pressing on the vena cava or directly invading the vessel wall will cause or intraluminal thrombus in that particular vessel, which will give this complication. So, here the patient will have puffiness of face, edema all over both the limbs, upper limbs, and neck also there is lots of swelling, because the blood is not drained into the heart. As discussed earlier, it is because of the tumor or node and usually associated with the malignancy of bronchogenic carcinoma, lymphoma, metastasis of breast, esophagus, colorectal and seminoma. Severity of the syndrome depends on the rapidity of onset of the obstruction. If the obstruction is happening slowly, the severity of the symptom will not be seen, but if suddenly happens, suppose there is a bleeding into the tumor or suddenly there is a increase in size of the tumor, there will be sudden compression of the vena cava and it will cause rapid onset and more severe symptoms, and generally takes several weeks for vena cava to get collateral to develop. So, collaterals are not developed, and that is why obstruction to the vena cava form will give you all these symptoms. So, in early stage the symptoms will be periorbital edema surrounding eyes, patient will get swelling or edema, then facial swelling, cough, dyspnea, dysphagia, difficult to swallow the food, and chest pain. These are the early signs. Later on patient will get engorged neck, so huge swelling in the neck, chest veins, tachypnea, plethora of signs and symptoms, upper extremity edema and cyanosis. Because of the obstruction to the blood flow, patient's blood will become blue and there will be cyanosis noticed in upper limbs. In severe cases, patient will have throbbing headache, blurred vision, altered mental status, seizures and papilloedema. Diagnosis of this condition is made by seeing the previous CT scan or PET scan reports and seeing the location of the tumor, location of the metastasis. You may anticipate this patient is likely to get superior vena cava compression. If most of the time these investigations are available, but on the day when the patient comes to you as an emergency, you can take proper history and clinically examine the patient, take a chest X-ray, CT scan or MRI of the thorax is also considered, where you can see the location of the tumor and compression, which part of the vena cava is compressed. Doppler ultrasound of the neck for the big vessels will also show you the signs of compression, or angiography may be considered, which is a last resort. What is how you will manage this situation? First of all, it is important to establish diagnosis. This may not be immediate threat to the life, but patient is very restless, dyspneic and having severe pain also sometimes, and most of the time trachea is also compromised. There is some pressure on the trachea also, so difficulty in breathing, and also he is very in distress, very much in distress. Firstly, evaluate the airway, whether patient is able to breathe, evaluate the oxygen level and start your treatment. So, if airway is compromised, you may have to go for tracheostomy or any other means to secure the airway, so can patient can breathe. Emergency treatment is required in this type of situation where airway is also compromised. First of all, make patient comfortable with head end of the bed elevated, start oxygen, give diuretics. You must remember that whenever you want to give any injections to this patient, the venous access should be secured in lower limb and not upper limb, because upper limb veins are compressed by the compression. So, in lower limb you secure the venous access and start giving injections if you want to give by parenteral route. The drugs which are given is start with the diuretics, steroids. This is medium to very high dose like 16 to 32 milligram of Dexona. If tumor is chemosensitive, a shot of chemotherapy. Radiation is the treatment of choice in many of the tumors which are compressing on the superior vena cava. So, sometimes intravascular expandable metal stent can also be considered with the help of scope. You put the stent right at the compression, and lytic therapy of if thrombosis is there, and venous access in lower limb only, which we discuss. Diuretics gives symptomatic relief, reduces the edema, but can ultimately cause systemic complication and dehydration. So, you have to check, keep on checking about the dehydration. chemotherapy only to the sensitive tumor, chemotherapy sensitive tumor such as lymphoma or small cell lung carcinoma. Radiotherapy you can give to any solid tumor, and if the obstruction of SVC is caused by a tumor that is not sensitive to chemotherapy or radiotherapy, then radiation therapy can be given to all types of superior vena cava tumors, compression tumors. In adults, the trachea and right main stem bronchus are rigid, but in children the trachea and bronchi are very soft. So, it can get immediately compressed. So, they have very severe symptoms, they may be asphyxiated and they have much more difficulty in breathing, and in the, children it becomes real medical emergency. So, take home message for the superior vena cava compression: make patient comfortable with head end of the bed elevated, start oxygen, secure the vein in lower limb, inject diuretic, steroid, and then consider the treatment options of chemotherapy or radiotherapy or stenting, etc. But at the same time keep the family informed, involve them in decision making, and patient autonomy is always very important whenever you are treating any palliative care patient. Next emergency we are going to talk about is hemorrhage, massive hemorrhage, means bleeding, profuse bleeding, and these are the patients who are likely to have profuse bleeding. Head and neck cancer is number one cancer in most part of India, like Gujarat, northeast states, where people have habit of chewing gutka and pan masala, and this patient they have got metastatic nodes into the neck. These are the metastatic nodes, and these nodes may be invading the large vessels, internal carotid, external carotid, internal jugular vein, which are going into the in the cranium. So, when the tumor invades into this blood vessel, it can rupture the blood vessel and patient will have massive bleeding, and it cannot be controlled. So, as discussed, cause of bleeding is because of the local vessel damage and invasion. Patient might have some systemic problem, DIC or platelet abnormality following chemotherapy or clotting factor deficiency because of the liver metastasis or any other pathology. Cancer treatment itself, right, radiotherapy and chemotherapy also causes bleeding because of the dysfunction of the platelets. Patient may be on anticoagulants. If patient is having DVT or some embolism, pulmonary embolism, and he is already taking anticoagulants, he is likely to bleed, and this bleed you cannot stop, or normal dose of NSAIDs drugs given for a long time will interrupt the platelet and clotting mechanism. Local infection at the site of the tumor, and that will within the tumor cavity, it will invade into the blood vessel and cause bleeding. So, first of all, try to assess the underlying cause. Here also, whenever a head and neck cancer patient comes to you with metastasis in the neck, you should check the CT scan. In the CT scan, you might see that the tumor is abutting the internal carotid artery or pressing on the jugular vein or something like that. So, keep this in mind, and these are the patients who are likely to bleed in future if the tumor invades into the vessels, or if the vessel burst because of the tumor. So, whenever you decide about the treatment, sometimes head and neck cancer patient has intermittent bleeding from the site of cancer like CA tongue or CA alveolus, lower alveolus, And this type of patient in as a preventive measure, you can do external jugular vein ligation. This is very common procedure, sometimes done taken up by surgical oncologists, and this is as a matter of prevention. This small procedure usually done under local anesthesia is taken up, and to prevent future bleeding or repeated episode of bleeding. Whatever decision you want to take, you have to keep in mind the general condition of the patient, general status of the disease, life expectancy and goals of care. Bleeding may be caused by trauma, ulceration, inflammation or growth that erodes the blood vessel. It can be external or internal. Sometimes the big vessel ruptures inside and the blood cannot be seen. And sometimes bleeding from the GI tract. If any GI tract tumor like tumor of stomach, cancer of stomach or large intestine or a small intestine, patient may get melena, that is a dark stool, hematemesis, rectal bleeding or vaginal bleeding, particularly seen in the cancer of uterus, cervix, hematuria when the cancer of bladder or because of the erosion of artery. So, bleeding from anywhere in cancer patient, you have to keep in mind that primary diagnosis and where the metastasis has occurred. So, bleeding exaggerated by coagulopathy associated with the disease or drug. Again, this is coagulopathy is very common in cancer patients, various type of factor deficiency, and that can cause coagulopathy. So, you have to keep that thing also in mind. Management of such bleeding, as we discussed, you have to keep in mind the disease status, condition of the patient and whether the treatable cause or not, then only you should take up the intervention. So, identify the cause with proper history and previous reports, correct the correctable, treat the site and stop any medication that causes bleeding like NSAID or anticoagulants or aspirin. Patient sometimes is on aspirin, you should stop that. So, management is firstly try to control it locally and then give any systemic treatment which is advisable. Locally you can apply pressure wherever possible, like if patient is bleeding from cancer of stomach, you cannot apply pressure, but if it is from outside and where there is a possibility of applying pressure, you do that. Local medicine, adrenaline, a gauze soak in adrenaline 1:1000 adrenaline solution, if it is put into the site of the bleeding in the tumor, that may help in causing vasoconstriction and stop bleeding. Tranexamic acid given orally or sucral fat by oral or rectal route. Systemic therapy contains tranexamic acid, ethamsilate and desmopressin, and localized therapy, adrenaline gauze, radiotherapy, immediate 3 sittings of radiotherapy for hemostasis purpose, cryotherapy, laser, embolization or surgery may be indicated. Many a times bleeding may be the terminal event, particularly in head and neck cancer patient. So, these patients should be evaluated well in advance, and treating palliative care physician should keep this complication in mind and prepare the patient and relative to face such situation. So, reduce risk, have drug and equipment at hand, psychological support, be aware of the risk, inform the care workers of the risk of the bleeding, and discuss with patient and carers. As I said in my one of the previous talk also, that whenever bleeding you cannot stop it, you have to cover the area with a dark towel. So, patient will not see the site of the bleeding and will become anxious, patient and relative also. Relatives are prepared well in advance, and patient is then sedated with morphine, haloperidol or diazepam, whatever is required, and make him as comfortable as possible. These top points are already discussed, like it part of the as a part of management. Keep patient, family, staff, even staff should know. Doctor might have read that CT scan report that tumor is invading the internal jugular vein, but nursing staff should also know and be prepared for this type of consequences. Unless one can treat the underlying cancer, wound remains unhealed. Avoid adherent dressing. In this patient, very adherent dressing, if you pull out the dressing, it likely to rupture the vein and vessel, cause bleeding. Keep the wound moist, direct pressure if actively bleeding, and medicated dressing soaked in aminocapric acid or silver nitrate solution, but usually we use adrenaline dressing or tranexamic acid dressing. Discuss with the patient and family if bleed is not stoppable. Again, dark towels and reduce the anxiety of the patient and caregiver. Another emergency, seizures, not very common in palliative care situation, but still it can be seen in a patient who are having primary or metastatic brain tumors and who had history of CVA, central stroke, or pre-existing seizure disorder. Many of the patient might be having pre-existing seizure disorder and which can worsen with the advanced stage of the disease. Less common causes are hypoxemia, metabolic causes like uremia, hypoglycemia, hyponatremia, sepsis, and drug or alcohol withdrawal. Approach to seizure: first of all, whenever seizures occurs, make the patient safely lie down on the bed. You should see that he should not fall or should not harm himself, and do not restrain. Do not attempt to insert anything orally. At that time, you do not try to insert the oral airway or give something by mouth. Recovery position after seizures is also important. Expect drowsiness for a while. Following seizure, patient is likely to become drowsy for a while, and call for help if seizure lasts for more than 5 minutes. First of all, take proper history, whether patient had previous seizures, history of seizure, and which medication he was taking, previous CT scan reports, whether he has brain metastasis or cerebral edema, or history of radiotherapy given to for the brain metastasis. All such histories are important. Proper investigation, go through it, correct the correctables, routine prophylaxis for seizure if needed. So, start medications like diazepam, Dexona, and whatever anti-seizure tablets he was taking. Phenytoin is the drug of choice, and in focal seizure it is carbamazepine is the drug of choice. Very few seizures go into status epilepticus, means continuous seizures lasting for more than 10 minutes, 15 minutes. In this, you protect airway and give oxygen if required. Consider subcutaneous route or IV route for the injection of the drugs, or if IV line is available, then you sedate the patient with lorazepam infusion, or even pentothal infusion, phenytoin injection, and phenobarbital infusion. If IV line is not available, you can look for the subcutaneous route below the skin or per rectal route for insertion of the diazepam, and it can be repeated every 10 minutes, or midazolam subcutaneous infusion, and consider steroid. These are the way in which you have to proceed with the management of the seizure. Start with lorazepam, then phenytoin, lorazepam, then phenytoin, 20 milligram per kg body weight. If not relieved, give midazolam 0.2 milligram per kg IV followed by a infusion. Again you give additional dose of phenytoin 5 to 10 milligram per kg, and then phenobarbital to be given in form of infusion. And when you are giving phenobarbital or pentothal infusion, patient may need securing the airway or may need intubation and oxygenation. Last emergency is hypercalcemia, which is occurring into the 20 to 30% of the cancer patient. It occurs in patients who are having both solid tumor and hematological malignancy as well. Patient with hypercalcemia due to malignancy often have a poor prognosis. So, normal total serum calcium is 8.5 to 10.5 milligram per ml, and about 40% is bound to protein and mainly albumin. Formula are available for correcting calcium concentration for a changes in albumin. So, depending on the albumin level, you have to decide the dose of the calcium. So, measured serum calcium plus 0.022 multiplied by 42 by minus albumin level. This is the formula given to calculate the dose of calcium you want to inject, correct the serum calcium. Common causes of the hypercalcemia are squamous cell lung cancer, squamous cell head and neck cancer, breast cancer, multiple myeloma, T cell lymphoma, renal cell cancer and ovarian cancer, and certain drugs like may contribute to hypercalcemia like thiazides and lithium. Symptoms are patient will complain of nausea, vomiting and constipation. There will be weakness, lethargy, confusion, coma. In renal, patient might have polyuria and increased thirst. So, it depends on the primary diagnosis and what is the situation of the patient when he comes as an emergency. Prompt treatment is initiated in patients who are symptomatic and whose calcium is very high, that is 13 milligram per percentage. First of all, hydrate the patient. You give IV fluids with 0.9% normal saline and then give diuretics, furosemide. Then bisphosphonate calcium lowering agent given parenterally. So, information, education and communication with the patient and family is extremely important for dealing with emergency. So, in hypercalcemia also you see the status of the disease, status of the condition, accordingly talk to relative, secure the vein, give IV fluid and give bisphosphonate therapy. Emergency can happen throughout illness, tragic, anytime emergency can ever, even if patient on curative treatment like chemotherapy or radiotherapy, then such emergency can happen and one has to diagnose the emergency and treat promptly. Management of palliative medicine emergencies emphasize on symptom management, then on attempt to reversing the disease process. So, first our aim is to make the patient comfortable, relief of the symptoms, particularly distressing symptoms like pain or dyspnea or bleeding, and rather than curing the disease. Thank you very much.